we started off with scheduling, and I kind of smiled when Nathan wanted me to do that, because I'm going, well, a great schedule is the result of doing a lot of other things before you got to the schedule. Case acceptance the same way. And so I, just as a point of review, I want to pull up 2 or 3 slides, just mention a couple of things that we've spoken about in the past when we were talking about other topics like the hygiene factor, or the other things that we were speaking about. So there are certain axioms or dental truths, and these 3 you could probably build a $5 or $6 million a year practice on. One is, there's absolutely no way to get better at giving people what they don't want. And oftentimes I have doctors, they tell me, well, I'm not getting enough new patients, okay, or I'm not collecting well, or I can't keep staff. Again, it all comes down to culture and what you're trying to give people. And when we talk about patients, oftentimes we become a hammer and nail. We go out and take a sleep apnea course, and then we diagnose everybody with sleep apnea. We go out and take implants, and that's all we want to do is do implants. We stop listening to our patients. And so as we move through this, we start talking about case acceptance, it's predicated on a set of systems and the fact that you have tipped a mirror up in front of yourself, and you need to just realize that if you are not growing at least 15% a year, you are not meeting your patient's needs. Bottom line, you're just missing the mark. Inspired leadership. Okay. I mean, it all comes down to the doctor. The doctor's number 1 reason you do well, but you're also the number 1 reason you do poorly. Okay. It hinges on you. The buck stops with you. If you want a new level of results, success, lower overhead, longer staff, you have to go to a new level of commitment. And you can't just keep doing what you're doing harder or longer. You got to go to something different. Now, the bottom line, we've mentioned numbers. We spent a whole deal on numbers, and then we sent you a bunch of information. Last week, we talked about the hygiene factor, and it factors, if not more important to what we're going to talk about today, hand in hand with what we're going to talk about today. And so I may refer back to that, but again, you got a 60-page document after that. This one on case acceptance, you'll receive another document that details everything. So my suggestion is we're talking, rather than trying to take notes or analyze this, is to really listen, open your eyes, open your brains, listen to this, and then you'll have the PowerPoint, you'll have the written data to check all the details. Okay. I want you to kind of own the process here. Everything you do is precisely designed to give you the results you're getting. So if you're not getting the results you want, you have to remember the strength of your practice, centers on those systems. Now, when we talk about systems, and everything we've talked about, from numbers to hygiene to scheduling to case acceptance, we talk about systems. They have to be scalable. In other words, great systems grow practices. Great actions produce great results. And so these systems don't need to be designed in such a way that every time you go from $100,000 a month, or $50,000 to $100,000 to $200,000 a month, whatever it ends up being, the system is scalable. You don't have to reinvent it. And that's why we're so particular on the things we're doing. It needs to be repeatable, flexible, okay? Regardless of what's happening around you, whether it's a bad economy, pandemic, economic collapse, like, the great recessions that we had, it needs to be flexible, sustainable. And remember this, with great systems, all people are replaceable. Now, I know that I can't see you, but I know the people that read and listen and study and own, they're accountable, they try to own their results in dentistry. The people who are listening to this right now, you are an exceptional dentist, but I wanted to define that for you just real quickly here. I mean, exceptional dentists are not chasing money. And I've been accused of, like, somebody will say, well, all you do is talk about money. Well, I don't look at money from the perspective of chasing a dollar. I'm really looking at money as just a measure, just some way to measure the amount of service I'm yielding to my patients. Okay. It's a very easy economic way. It's quantifiable. I can look at it. And so these percentages, these dollar amounts mean something. Okay. Exceptional dentists, they're serious about the profession. It's not just a job, it's a profession. Okay. They embrace change. This is a tough one for most people. Most people resist change. Nathan's one of those that embraces change. You know, I always looked at change as an opportunity. Certainly it's a challenge, but it's always an opportunity too. And they concentrate on being a team member. In other words, I'm no better than any staff person that I work with. Okay. I am just another set of hands doing the job I can do. Now, the problem, and Will Rogers said it pretty well, the problem in America isn't what people don't know. The problem is what people think they know that ain't so. And you know, it's no more prevalent than when you look at Facebook. I was reading a post today on dental nachos, and they were going, oh, I'm going to be graduating from dental school in a year, you know, at the end of the year. And, should I be asking for, you know, $200,000 or $300,000 when I get out? I just don't know what to ask for. I mean, how stupid is that question? I mean, you're looking at this. We're graduating 6,800 dentists a year, and less than 50% are becoming owners. I mean, the culture of graduates has totally changed. And as an employee, you're you're just exposed to whoever the owner is. And again, they're exposed to their overhead. So anyway, I think that by the questions from the people that have called me and emailed me and texted me about these programs we've been doing for you, they had great questions, but I'm also surprised at some of the questions. There were no stupid questions, just I was surprised that owners and practices were still struggling with some of these basic things that they should already know. Now, we're talking about case acceptance. And I've been asked this many times, you know, like, what is real case acceptance? And they go, well, what if they show up, say want to do it, but they don't come back? Or what if they do it and they only do part of the treatment? Or what if they, you know, we present something, they don't want to do that, they want to do something else? I mean, what is true case acceptance? Okay. It's having a patient who shows up, pays for the treatment, and refers everyone they know. Now, if you think about this, if they show up, okay, because you've seen them once, at least once, and you've diagnosed them, told them what it's going to cost, done the financial arrangements, and they come back, you've done something right, okay? If they pay for their treatment, I mean, I see people show up, and when I forgot my checkbook today, you know, or they don't pay for the treatment. Or, you know, you look at where your new patients come from. I mean, the default monkey score for patients is 20 to 30 a month. If you're not getting that, there's something real, you're doing something actively to push patients away. And so if your referrals aren't 50% or greater, there's a whole lot of room for improvement. So again, true case acceptance, they show up, pay for the treatment, refer everybody they know. Now, if we look at the goals, and remember, if we think about case presentation, I think most doctors think about case acceptance and case presentation, and I'll use those kind of interchangeably, but I see doctors thinking that this is some point of time in the future when I have diagnosed the patient's mouth and I tell them what's wrong and they say yes or no. That's where everything happens. It's not. That's so far from the truth. It starts from the very first time that they called your office, that initial phone call. It happens when they walk in and the front desk person didn't stand, address them by name. You didn't appear caring, compassionate. You weren't remarkable. You were just like every other dentist. And believe me, no one needs another average dentist. Okay. And 90% of the people outside of your office are not looking for a dentist. So you're either remarkable in this profession that we've chosen, or you're invisible. Okay. So highest acceptance occurs with no formal presentation. Believe me, I've been to Pankey. I've been every place you can go. And I grew up thinking that, I'd have them come in. I wouldn't clean teeth on the first appointment. I'd have them come in for, a 2-hour fact-finding deal. I have them come back with their significant other to talk about the benefits of comprehensive dentistry, and then try to work that into the budget, give them the big ticket items, and people would just fall over me and have their dentistry done. Yeah, I didn't see that happen. But about 35 years ago, I went and it was called the Auxiliary Oriented Diagnostic Appointment. And Gordon Christensen put out I'll tell you how old it is. It was a VHS tape. I still have it somewhere. Now, they don't call it the patient, what I just said, he put so much on the staff, like he came shoulder to shoulder and partnered with the staff so that the total experience was incredibly good, was remarkable from the patient side, but it minimized a lot of the doctor carrying the weight of case presentation, because they were working towards that goal, staging it from the very first phone call to the point where they had the opportunity to say yes or no. And that was where it was lost. It wasn't lost when you told them what was wrong. Okay. But number one goal, never lose a patient. Okay. If you're losing patients, and again, the average, this is just so horrible. The average case acceptance in an average dental practice is less than 60% today. Are you kidding me? Less than 60%. So you're losing 40% of the patients that come in to see you. And usually the reason they didn't work out is you didn't answer the questions about time, money, fear, and they didn't trust you. Now, remember this, because we talked about this in hygiene. 67% of all the dentistry you're ever going to do in your offices come out of recall hygiene, not out of new patients. 67%. Okay. Number two, one goal is to never be perceived by the patient that you're trying to sell them something. Now, maybe the number one reason patients say no is when a doctor is perceived as wanting the dentistry more than the patient does. And we're going to talk about different, the aspects of this, but if you come across and the patient is thinking, man, he really wants me to do this, you've lost the patient. You never get back in front of them. Confrontational, balanced. I mean, we have assertive doctors and non-assertive doctors. We'll talk about those. You need to mirror the type of person you're sitting across from, where they're, expressive or drivers or amiables or, analytical folks. You need to reflect that back. And again, I see a wide spectrum of personality traits in doctors as well as I do in patients. The trick here is becoming what that patient needs you to be. To move, if you had those quadrants of, amiable, analytical, expressive, driver, and you drew the boxes, right in the center is where you need to be. So you're close to each one of them. You have to become an expert at this. Remember, anything that you diagnose, it's always worse than they thought. Okay. Now, there are a million people out there teaching case acceptance, and you're going to find this is going to be really, really simple, because it really, really works all the time. And surprisingly, there's not some secret sauce to this. And if you think about it, if you think about the restaurants you go into that you thought were remarkable, it wasn't just the food. You think, okay, if they have great food, then everybody's going to come there. Yeah, it's not it. If that were true, every cosmetic dentist in the world would have every patient in the world chasing them. If they were the best person, they're not. Oftentimes, they barely make a living. Okay, so every approach works with someone. Our goal is to get over 90% acceptance. Okay, validity is a word that means, kind of you're the it doctor. Okay, when they think of your office, it's kind of like top of the mind awareness. Okay, it's like they fall out of bed, and hit the floor, and they think of God, family, and Mike Abernathy. Okay. I mean, it's like you want that type of effect in the 4 or 5 miles around your practice or with the patients that you affect. Okay. So no stress and there's no selling. It's just a discussion. But all of the discussions are staged to get to the point of case acceptance. Now, if you remember in the hygiene factor, we were partnering with a hygienist or in the case of an emergency patient, an assistant to preempt us to the point that all of the questions had been answered for the patient, educational material, photos of the mouth, x-rays taken, explanations of what the doctor might recommend. They're not diagnosing you, they're just triaging. But again, you have to remember, when it comes down to it, you're not selling root canals and crowns and fillings and straighter teeth. You're selling solutions to problems and good feelings. Okay, now, again, the easiest person to sell something to is somebody who owns a problem. They're hurting, it's Friday afternoon. They do not want to go through the weekend with a toothache. They will pay for an extraction or they'll pay for a root canal. Real easy to work with. Easiest doctor to work with. Someone that can't pay his bills. Okay, they need a solution to the problem. And then good feelings would be the cosmetic dentistry, right? No one needs 8 veneers. They don't. It's not normally a solution to a mechanical, and they can eat without that. Okay. But normally they want it because they want that smell. They're the type of person that would go out and buy a car with fine Corinthian leather. Okay, nobody needs leather seats in their car or pickup truck. They just need seats, but it makes them feel good. So you're selling solutions, problems, and good feelings. Keep that in mind as we're talking about this. We're not selling the procedure, we're selling solutions to problems and good feelings. Okay. Now, the other is, you have assertive doctors and non-assertive doctors, and oftentimes we think, because we went through dental school, and of course, everybody that teaches dentistry in dental school is not an expert at this, but they've taught us to educate our patients to the point of buying something. And that buying decision is never going to be logical. It's always emotional. So the trick in helping somebody want what they need is to find out what that emotional button is and push it. Okay. They want their dentistry. Okay. I mean, this is going to sound so simple. I mean, I would say 90% of the dentists that I see their work, it's not excellent. It's like they've forgotten the basics. They don't understand the mechanics of what they're doing. But your patients, what they're looking for is something that looks good, feels good, and lasts a long time, right? Looks good, feels good, lasts. That is the matrix that they put in front of the dentistry you deliver to them. Does it look good? Does it feel good? Does it last a long time? Now, they may reorganize that statement. It needs to feel really good. Oh, yeah, and it needs to look good too. But it needs to really last a long time. But if you could give that to a patient, you've over-delivered. Now, what does case acceptance depend on? Now, it is, you'll notice there's a group of people pushing this heavy ball uphill. And if we talked about hygiene factor in these numbers in your practice, anything worthwhile doing is difficult. It seems to always be uphill. And so with a patient who walks in with no rapport, you have no validity with them, they make a phone call because somebody referred them there, or you've done some marketing and they come in, you start from zero. Okay. Now, I won't go back over the hygiene factor. And I know that the material I sent you was long. I think it was 67 pages. But it is so integral to this case presentation because if done correctly, this would be like if the hygiene factor was put in place and it worked well, then this would be, when it came to your part of the case presentation acceptance, it would be like standing on the 18th hole, tied in the Masters, and your Tiger Woods, and your caddy walks over to you and goes, the wind's moving from left to right at 5 miles per hour. They've moved the cup today. It's on the, the front left, just at the edge of the green. The green is going to run from left to right at a 45-degree angle. It's only this distance. So you just need to hit a full 5-iron straight in, to the right side. It'll carry, it'll drop right on. It'll be perfect for you. Tee up the ball, hand you the club, and all you have to do is make the shot. I mean, everything was done to you for you up to that point. And so your part of this is so easy. So I wish we had done the hygiene factor and this together, but that's a lot of information. But I'm going to go over just a couple of points here. Okay. In the hygiene factor, the hygienist is staging everything. They're going to find out what the patient wants, what they need, and what their dental IQ was. And I gave you an example last time where I was talking about Mrs. Jones and going through it. And basically all you had to say at the end after the hygienist, did her part was, well, Mrs. Jones, it sounds like you'd like to do that lower right crown, those 2 fillings, but we're going to wait for the other 2 on the other side. And she's going to say yes, and you're going to tie urgency to it. All it's going to be left to do if you do this well is you're never going to need a patient coordinator in your office, because all the questions will be answered back there. All of the consensus of what the patient wants to do will be done back there. It'll be merely walking to the front, and they're going to need to help them fit it into their budget. Incredibly different type of format than I see in offices. And these offices all struggle. They all struggle. Okay. Now, we have 2 different types of doctors when it comes to case presentation. You also have this with staff, but since we're kind of talking about doctors here, same thing with hygienists, especially. You'll have assertive doctors and non-assertive doctors. Now, we'll just abbreviate the assertive doctor as ASS. So the asses kind of overwhelm the patients. They're perceived as pushy and overbearing. They're like, they've got a messiah complex. They go in and they're the, I can't say the names of these doctors that I know are this way, but they're people and they teach cosmetic courses. And they'll go in and, they basically just, they'll say, okay, Nathan, do me a favor and smile one time. Let me smile just a little bit. Oh yeah, oh, put your lips together. Oh yeah, no, okay, yeah, please put your lips together. Okay, yeah, we can fix that. It's going to take 32 crowns, but I think we can get this done for you. And then they're surprised when the patient gets to the front and they want a second opinion, or they need to talk to their spouse, or okay. So if you're overly assertive, what's going to happen is that no matter how you do arrange your case presentation stuff, you're overwhelming the patient. They'll come to the front and they'll go, I need to think about it, or I need to talk to my spouse, or I need to get a second opinion. And they're gone. They're never coming back if you're overly assertive. Okay. Now, we talked about assertive and non-assertive doctors last time with hygiene, and I'll refresh your memory in just a second. But assertive doctors are kind of, a legend in their own mind. They don't listen to the patient. Remember, what we needed from the hygienist is, before I get to talk, I need to know what the patient wants. I'll see what they need. I'll need to know what their dental IQ is and kind of what their budget is. And I'm going to change the way I talk to the patient based on those things that they give me. And then on the far right side, we have the non-assertive doctor. Now, this is the doctor that will only tell the patient what he thinks or knows they'll say yes to. I mean, it may need, a crown, and they'll talk the patient into an MODBL pin, composite or amalgam filling. I mean, they are so approval addicted. They're so fear-based. They so much want the patient to like them that they just won't tell the patient what they really need. And so you can tell if you're non-assertive if they get to the front and they go, the front desk person, they're talking to them, and they go, I have no idea what Dr. Abernethy wants to do next. They're just confused. They're unclear about what your recommendations were. And so keep this in mind. as funny as that may seem, we have assertive, non-assertive doctors. We have got to get somewhere in between based on the personality profile of the patient we're working with. Okay. So the goal here is to give the patients more of what they want and less of what they don't want. Now, in that vein, the assertive doctor has no problem telling the patient what they need. He has a problem giving them what they want. Now, the non-assertive doctor is more than happy to give them what they want, but he just won't tell them what they need. And so if you've ever done this, now you ask your staff, let them watch this, because you're not a good, you're not good at really, I mean, most dentists are kind of have great self-image for no apparent reason. They tend to think they're doing a better job than they're really doing. And generally the results will show that they haven't grown. People don't come back. They don't have direct referrals. Their overhead's terrible. I mean, that's your patient screaming at you that they're not inspired and they don't like what you're doing. And so you've got to take a hard look at this. But if you've ever had this happen, and your staff will tell you this, yes, no, you do your case presentation. Let's say you did a chair side. There was a hygienist or an assistant there, and you turn to the patient and say, "Do you have any questions?" And they go, "No." And so you excuse yourself and you leave. Ask them what happens after you leave. Because if the patient turns to the team member that's in there, that hygienist or that assistant, who they feel have no reason to sell them anything, okay? If they start asking them questions after you leave and telling you that they didn't have any other questions, you did everything wrong up to that point. Everything wrong. And we need to get past that, okay? So we've talked about never losing a patient, okay? One of the things that assisted hygiene does is it does not tie patients to the practice. And so it is a real, in hygiene, it's one of the reasons that, again, you can produce a little bit more with your hygiene area, but the patients won't get on your schedule. Okay, so never be perceived as selling. What was the, Nathan, it was called A Team of Their Own. You know, with Tom Hanks, had a girl baseball league back in World War II, and you know, Gina Davis starts crying in the middle of a game, and Tom Hanks, who's a drunk coach that used to play baseball, he stumbles out. He said, "There's no crying in baseball. What are you doing? There's no crying. There's no selling in dentistry." Okay, if you stage this properly, it's not going to come across as selling. And remember, if they perceive you're trying to sell them, that you want this more than they do, you will never get patients you'll stuck at 60%. Okay. Confrontationally balanced just means, you know, making sure that if I were talking to Nathan, he's real expressive. I'm going to show him a picture of before and after dentistry. You know, I'm really going to listen hard to it. And now, if it was me, you just say, "Mike, you need a crown. It's going to cost $1,000. It'll take us an hour to do. Would you like to do it today?" I said, "You sure it's going to take an hour? Hour and 10 minutes. And, you know, what's the cost?" He said, "It'd be $1,000. Great, let's do it. I have no problem." And then the engineers that we had, like from Raytheon and TI, you know, I had a thumb drive that I gave them that had all this dental materials stuff on it, because they'd ask me stupid questions about the shear and compressive strength of a disilicate block milled in a CAD/CAM generated milling machine, and then stressed from, you know, lateral stresses of a certain poundage per square inch and temperature gradients, and, you know, it just was crazy. But I got confrontational balance, and every one of our staff did too. They could identify their personality and they could get in step with them, and it just made it so easy. It was like we were talking their language. Usually we talk our own language and people don't hear what we thought we said. Now, the paradox of choices. Now, you're required by law to tell them what they need. Okay, what's wrong and what could fix it. But you also need to listen and find out what they want, because every patient will make an appointment to do what they want. And so when we do financial arrangements, no matter what's on that treatment plan sheet, we always start with what they want first, because they'll come back for that and they'll pay for it. I get one more time to show them what an incredible experience they could have, and that it's going to look good, feel good, last a long time. It's not going to hurt. It's going to take less time than they thought, and we'll figure out a way to fit into their budget. But if you give them 3 or 4 choices, like a partial, an implant, a bridge, just tell them what you would do for your own family. Paradox of choice actually creates, it increases their expectations on what you can do. They become very anxious and nervous about making that decision. I mean, it's all bad, okay? So limit what you tell them, be positive in your own mind that that's what you do in your own mouth, because it's easy to come across as passionate about what you think they should do when you do that same thing in your own mouth, okay? Number 5 is basic that, tell them your opinion and support it with confidence, okay? It's always worse than they thought. Now, as we said, everything works with someone, okay? And remember, okay, they're buying the solution to problems and good feelings, okay? Now, if we walk through the actual steps in case presentation, I've divided it into 6 categories. Now, each of these have a script that I used. And I'm fine with you changing the script, but I need you to be thoughtful about what I'm telling you and what words I've chosen to use. And certainly you can put, Nathan can Nathanize it and you do what he says. But you want to make sure that the perception of the patient is kind of what I'm telling you. Now, the permission statement came from Zig Ziglar's Closing the Sale. It's a 40 or 50-year-old book, but you see it every day. You walk in a car dealership and they'll go, is it okay if I show you a couple of other models that you might be interested in? Just a permission statement. Okay. Now, in a dental office, it's like this. You just tell them, it's Mrs. Jones, I feel like my job is to do the finest dentistry I can do, the same dentistry I do in my family if they weren't paying for it. Now, you have a job too. You get to decide if you want to do some of it, all of it, or none of it. How do you feel about that? Now, I want to go over this 3 or 4 times. I want you to hear what I'm saying. They've never heard this in a dental office before or a medical office. Okay, 1, I want to set the ground. Like if I were selling something like a car, the smart thing to do is to point out all of the negatives about it. Okay, like just disarm them. Just say, look, the trunk won't stay open. I bought some new air shocks for it, but it's a 1968 GTO Judge, and I meant to put those on. I never got around to it. There's a little tiny scratch on the lower right quarter panel. My son did that one day. This is a $10,000 paint job. One day after I brought it back with his tricycle, it didn't go through the paint, but there's a little scratch there. You show them that and it just disarms them. So what I'm going to do is, in every one of these steps, I am giving them the perception that they're in complete control of what we're doing, but they're not. Okay. So permission statement again. Mrs. Jones, I feel like my job is to do the finest dentistry I can do. Your job is to decide if you want to do some of it, all of it, or none of it. No patient has ever been told that they can do just some of what you present, or you could do none of it. So they're going, okay, you're giving me permission to do some of it, all. Yes, ma'am. Now, I notice you have insurance. Number 2, I notice you have some insurance. Now, this came from Walter Haley 20 years ago. Okay, Walter Haley. Now, I don't know if you have good insurance or bad insurance, but if we find something your insurance doesn't cover or doesn't cover all of, what would you like us to do? Now, if we look at the permission statement and we look at this insurance that I just did, remember we had assertive doctors and non-assertive doctors. Our job is to make a non-assertive doctor look more caring and compassionate, because they're not. And we're trying to make the non-assertive doctor look more competent, which they're not. Okay. So we're trying to move them, and by doing this, you're going to come off, if you're really assertive and you go, Mrs. Jones, I feel like my job is to show you the finest interest I can do. Your job is to tell me you want to do some of it all or none of it. Okay. I mean, but at the right pace. Okay. When I come to the insurance, I'm going, oh, hey, I noticed you have insurance, because we want to point out the things that cause blockages in the future if we don't do this. Now, we've all heard this. I only want to do what insurance pays for, right? We all heard that. Or what will my insurance pay for? Okay, now a non-assertive doctor is not going to present something that the patient doesn't give them permission to tell them. Now, the overly assertive doctor may come up with 90% of the case presentation with things that the insurance won't pay for. So we're going to get this out of the way right now. Nathan, now notice you have insurance. Now, I don't know if good insurance or bad insurance. Now, patients never heard this before either. They're thinking like, good insurance, good, good. Okay. They've never heard bad insurance. And we're putting this seed in their brain. I'm not, Nathan, I don't know if you have good insurance or bad insurance. I'm just stupid about insurance, kind of, I don't know if you have good insurance, bad insurance. But if we run across something that it won't pay anything on or won't pay all of, what would you like me to do about that? Now, in both cases, permission statement, Mrs. Jones, feel my job is to show you the finest interest I can do. Your job is to do some of it all or none of it. How do you feel about that? I'm not saying, is that okay? So they can just go, I need them to thoughtfully respond to my question. So on the first one, how do you feel about that? They're going to say, well, because I ended it, oh no, I can make that decision. Yes, no problem. Thank you. And then we got insurance, good or bad. What if we get, they're going to say, oh, how do you, what would you like us to do about that? They're going to go, well, I'd rather you just tell me about it and then I can make my decision, which told the non-assertive doctor it's okay to tell them that they need a crown. Okay. They're not going to be held back, but it's going to make the assertive doctor look more caring and compassionate. Now, the diagnosis and comprehensive exam, again, it's always worse than they thought. I would say of the new patients that come into practices, probably 70, 80% have no symptoms, right? They're not coming in going through hygiene. Now, if they had a broken tooth, they might come in saying, I got a broken tooth. But I'm talking about somebody just comes in, first time, they're going to go through hygiene, and okay, it's always worse than they thought. So selling a comprehensive exam is real important. Okay. Now, we insert the hygiene factor here. Or if it's emergency, we insert kind of that staff factor where they're going to do all those things for you, triaging the patient, answering the questions, talking to them, saying things to them like, well, now I noticed on the bottom down here, you're swollen. It appears you may have an infection and it's broken real badly. You have this big filling. The doctor, are you interested in saving the tooth? And they go, absolutely. And said, well, the doctor may recommend a crown. Do you need to know what a crown is? And they talk about that before you get in there. Now, I will remind you the 2 times that hygienists are upset at you are when they're waiting on you to get there. And when you get there, they want you gone. Okay. So if we can stage this in a way that allows you to get there at a point where the patient, there's already a consensus of what they want. You'll know what their budget is. You'll know, what their dental IQ is, and you'll know what they want. That can go really, really quick. I saw Gordon Christensen do 2 or 3 of these. He's a board certified prosthodontist. He spent less than 3 minutes with the patient. Now, the patient was there with the staff, the people you partner with every day. And so they have to be trained well. And you've got to, really embrace this. They answered the questions better than you could ever do it. So again, the hygiene factor goes in there. And then the case presentation is just a dialogue. Now, I'm going to replay this for you with the same patient I used, but a little different in the last time in the hygiene factor. And so the hygienist, I walk in, it's just a recall. And Jenny goes, oh, Dr. Adderley. And I walk in, I do not have my mask on, I do not have my gloves on. Okay, I walk in and they go, Mrs. Jones was in here 6 months ago, and on the lower right, there was a tooth that was a little sensitive to cold, and just ever so often pressure, but it's gotten a little bit worse. And so I took x-rays, and then I didn't see any decay. But when I took a photo of the tooth on the outside, on the front corner, I could see a crack. And so I had her bite on a Q-tip, and I moved it around the tooth. And the only spot it was a little tender was right on that front right point of the tooth. She didn't say on the mesial-buccal cusp. Okay. You're hearing again what the patient heard. Okay. I told her you might recommend a crown, since it has this huge black mercury filling in it. There's hardly anything left of the tooth. And she'd like to do that. But she also asked me about those two fillings that you did 35 years ago, right in front of it. And they're not very big. There's no decay that I could see. But I was showing her a crown in my own mouth, and she wanted to know if we could make those black fillings white. And I told her it wouldn't take you 10 or 15 minutes to do when we did the crown. And she'd like to do that. Now, she came in and she has a little tiny chip on her front tooth. And I told you, be glad to smooth it off with a Softflex disc. I've already got it out for you. But I did, even though it wasn't time to do x-rays, I did take x-rays of the next to the back teeth, top and bottom on the left-hand side, because I was looking at the record. You did those 35 years ago, same size, huge. I didn't see any cracks or breaks. They're not sensitive, no decay I could see. And the whole time she's talking, I'm looking at the teeth and agreeing with her and saying that, yes, I agree with you. You need a crown there. And, blah, 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 and just going around there. And so here's what she told me about food. She said, I told her that she might consider doing crowns on those next to back teeth, molar teeth, in the near future. She'd like to wait on those. So in effect, she told me what the patient wanted. They wanted the crown, the two fillings. They wanted to wait on the left-hand side. But she did more than that. If I was the overly assertive doctor that was going to just hammer the patient to get them to do more, she was basically saying, look, dumbass, if I could talk her into doing those other two crowns, I would do it. Do not try to sell those crowns. We'll get to do it in 6 months. Just don't do it. But she's also telling the non-assertive doctor, look, she wants the crown. She needs the crown. Do not do an MODBBBL, facial composite. Just nod your head yes. Okay, so in effect, if we do this right, we've staged everything perfectly. It's not a moment in time when the patient says yes. We've staged everything up to the point where the patient can say yes. We've helped them want what they need. Then all I have to say to leave in and out after she gets through is, well, Mrs. Jones. And again, I use neuro-linguistic programming. I touch her shoulder, arm, just, it's not weird, just touch. I say, it sounds like you'd like to do that lower right crown and the two fillings, and I'll smooth your front tooth for you here in just a second, but we're going to wait on the other side. And she goes, absolutely. And so all I have to do is say that it sounds like you'd like to do what she said she wanted, and then I'm done. But before I leave, number 7 would be, I turn to Jenny and go, Jenny, even if you need to move someone, I don't want her eating on this cracked tooth until we get it fixed. So I'm planting a seed in the patient's mind that there is a time-sensitive period to get this done. And I said, Jenny, even if you have to move somebody, try to get her in the next couple of days. I just don't want her to, and Mrs. Jones, whatever you don't chew on that tooth until we get it fixed. She's, oh, okay, fine. And I leave. Okay, that's it. I mean, it's that simple. Now, in the literature I'm sending you, it goes into great detail of how we've staged this and the words we choose to use. Every word has a meaning. Now, when we talk about the paradox of choice, okay, too many choices, expectation goes up, that's going to be bad. Eliminating choices, okay, and not giving them more choices decreases their anxiety. If I said, Mrs. Jones, we're going to need a crown in that tooth, okay, and I used a script in the hygiene factor, and we've all had this happen. The patient's coming back and they're going to do a crown, and they turn to you right before you numb them and go, do I really need that crown? Okay, here's a great script. And you make it age appropriate. Like for Nathan, if you said, do I really need that crown? I said, Nathan, if you were my son, we'd have done that crown 20 years ago when we put the filling in there, because my son wasn't paying for it, but that's what I do in my own mouth. Or if it was somebody older, if you were my mom, that's what we'd be doing to my mom. Okay. So again, eliminating choices is good. And again, I don't know if I've mentioned this already, but right at the first, I think I was talking about being hammer and nail. One of the worst mistakes you can make is thinking patients want what you have to sell them. Now, let's say Nathan goes to a sleep apnea course, one weekend. Oh, he's an expert. Comes in on Monday morning, and out of the 8 patients he saw in hygiene, 5 of them need sleep apnea. Now we know the percentages aren't that high, but you become a hammer and nail. And so make sure that you're not so enamored with doing 6-month smiles or implants or veneers or whatever it is that you stop listening to the patient, finding out what they want. Okay. Now, why do patients say no? Okay. We said this earlier and I didn't explain them: time, money, fear, and trust. Of those 4, okay, time is, do you have consumer hours? Can you fit this into their schedule? I mean, or let's say it takes you a lot of appointments to get through. I mean, if your clinical speed will always have some component in this. If it takes you forever, or you can't do quadrant dentistry, or you can't do half of a mouth or all mouth at one time, you can't make the patients comfortable, or you just can't do it, that's going to be a problem. Money's always a problem. The average patient can't afford one out-of-pocket $500 expense without reaching into their savings. So anything that you find is going to be a money problem. Is there any surprise that people would like to be in an in-network doctor when they do their dentistry? Knowing that? I mean, I don't like insurance either, but sometimes you can't pull off being a fee-for-service doctor. Okay. Fear. I mean, I don't think, well, I've never owned an office that we didn't have nitrous oxide in every room. We had IV sedation, anything that they wanted to make them happy, have a trip and never leave the farm. Okay. Not staging every step is one reason people say no or don't say yes. Okay. I mean, from the very moment they came in or called on that phone, we're creating rapport with the patient. We're inundating them with culture. We're giving them more of what they want and less of what they don't want. Okay. This is a good one. I see doctors, this used to be very common, that we mentioned this. The patient comes in and you do a comprehensive exam and then they come back with their significant other and we talk about it. But even just as bad is not cleaning teeth on the first appointment if they're not perio. I mean, there's only 2 things patients call for. I've got something wrong with my tooth, I can see a dentist, or I want to get my teeth cleaned. And if you don't clean their teeth on that first appointment, you're never going to see them again, and they're not going to refer anybody to you. Okay. We've already talked about thinking the patient wants what you have to sell. Okay. The doctor wanting the treatment more than the patient does. I mean, I don't think you actually be interesting. I used to film myself doing case presentations. I would just turn on the little camera in the corner of the room and record it. And I couldn't believe all the things I said that were so bad. It was just terrible. So again, really be engaged in the process of improving how you process your patients. Not partnering with the team. I mean, I've had doctors that go, especially young doctors. I mean, I don't think how your hygienist was trained. I mean, they can't legally diagnose, but when they were in dental school, they were going to hygiene school, they were tasked with seeing 2 or 3 patients a day for 2 years. Okay. Every day they would put down existing conditions, probing depths, cancer screening, charting any dentistry they needed, cleaning their teeth. And then once they got through and they all in the computer stuff, a dentist would come by and they would look at all the x-rays and chew their butt out if they missed diagnosing anything. They can read the x-rays. And if they can't, find another hygienist or sit down with them and help them, because that's the best way for her to help you get the patient to want what they need. Okay, not just telling them what they need, but want what they need. Okay, too many options. We talked about that. There's rarely any follow-up. I have yet to walk into an office where they actually work on following up on dentistry that was not completed. And with a 60% success rate, and then that's just in having people say yes. If they stop in mid-treatment or don't come back, you guys don't follow it up. I'll have doctors run reactivation reports like how many patients haven't been in here in 13 months. It'd be thousands of people. They think all these people are coming back on hygiene, and they're not. Okay, so there's rarely any follow-up. Poor financial solutions. I think financial solutions for most offices carry credit, the worst of the worst. It's a credit card company that can charge your patients 20-something% if they miss a payment. There are a lot, and they're, depending on where you are. I mean, certainly you could be in Jackson, Mississippi, and they may not have anybody that they'll qualify. But the average office is going to be between 50 and 60%. So there's 40 to 50% that aren't getting qualified. There are companies out there that will qualify them. They may not loan for the total amount, but we have to become experts at fitting, what they want to do into their budget. And that might mean 2 or 3 outside services. So for example, let's say, and I've never had this not happen. I talk them into a different company, and they're still using Care Credit, and they just, so they use Care Credit, and Care Credit won't cover it. And the office doesn't even ask them, well, what will you cover? And they said, well, of the 5,000, we'll only cover 2,500. Great. So you call another one, another group, third-party lender, and they'll cover 2,500 or more. And you use both of them to do it. And you get the work done. Okay. Or you find that the other one will loan all of it for a longer period of time, and you don't go back to Care Credit. So you need to find some way to get 90% of your patients financed if they want the dentistry. Okay. And again, it's surprising how many patients that come into my office and you diagnose them and no one has ever told them that they've got 6mm pockets around their teeth, or that the movement, it's not normal for every time they breathe for their front lower teeth to move in and out. Okay. So how do we create phantom pressure? Now, we talked briefly about what you say and what you do, but there are some things you can create phantom pressure. I remember having, when I got to McKinney, there were 3 or 4 older doctors in McKinney that were, in their 60s, early 70s. And as they got older, they died. Most of them didn't sell their practices. They just closed the doors, and all the patients ended up in my office. But again, I remember a Dr. Burroughs, and it was really just supervised neglect. He had no hygienist, never cleaned the teeth, never took x-rays. It really was terrible. And so again, patient would come in and they'd go, oh yeah. One was Dr. Minton that I used to work for. And he goes, oh yeah, and Dr. Minton had passed away and practice had closed. And he goes, oh yeah, I went to Dr. Minton. He's one of them good dentists that he don't using them little bitty hygienist little girls that run around and do stuff. I mean, he's a real dentist. He did it all himself. There's going to be a problem. We've all had this happen. They're talking so many positive things about their old dentist that passed away. And and she looks at him and goes, okay, and we're not taking a 18 film, FMX. We're just going to take a Pano because, it's going to be cold steel and sunshine. It's terrible. The only thing holding the teeth in was a calculus bridge on the lower. And so I'll walk in and go, Mr. Jones, hey, I work with Dr. Minton, really good doctor, but I bet he said he's been keeping an eye on something, correct? They go, yeah, he did say that. Well, I'm looking at his teeth. I don't think there's anything I can do to fix these. I think you're going to need dentures. And look, I don't want you to feel like I'm, just trying to get you to do something. So I'm going to go ahead and print that x-ray we took, and I'll be glad to write down everything that you need to have done. And please go get a second opinion. I just want to make sure you get someone to help you. 90% of the time they won't go anywhere else. They'll turn around and say, well, I kind of knew my mama had dentures and my daddy had dentures, and, just take those son bitches out and, I'll He said, but could you do this? And he reached up, he actually reached in there and grabbed a 4-unit bridge on the upper and pulled it out. And you can see the roots, right? Sticking up. It's still on the teeth. He says, can you glue this back in until we can do my denture? And I went, I'll get you some polygrip samples, but I don't think I can just glue it into the, the soft tissue up there. Okay. So second opinions, it's phantom pressure to get them to follow through with what you want. I mean, you have nothing to hide. Give them whatever they want. Reciprocity. I mean, in Robert Cialdini's book, Art of Persuasion, reciprocity is in a way like, for example, in the old cafes that you go in and eat in McKinney, the waitress would come over and give you your check and set 2 peppermints on top. Okay, that's reciprocity. She gave you a gift and she's thinking, well, I'll get a tip. Okay. Or let's say, Nathan, we were at one of your big seminars and you're sitting at the table and I'm going, hey, Nathan, I'm going to go outside and run downstairs and buy a soft drink to drink. Would you like me to get you one? You're going, well, yeah, thanks. So I give you the drink. And let's say at the end of the day, I'm going, hey, I can call Uber, but I had a problem in my car when I came here the other day and I left it at the shop over here. It's like 2 blocks away. Is there any way that you could give me a ride? Now, what I have done is I gave you something, so you're indebted to me a little bit. Okay. You'll go out of your way to get out of that. And so we all give people gifts, when they come in for cleanings, toothbrushes, little bitty gifts, floss, stimulants, whatever it is. If you will give those on the way in rather than at the end of the appointment, when you do case presentation, the reciprocity part of this will have them more open to following through with it. Now, on all of my new patients, and I didn't say this last time, but I always call them the day before. It happened about 2.5, 3 years before I sold my main practice. And I was looking for a way to be more competitive with the 2 doctors that were my partners. Okay. They never produced as much as I did, but they got really close. And so I was, got that little guy mentality. And so I'm going, how could I, what can I do to, if we're going to have a fist fight, I'm bringing a knife, or we're having a knife fight, I'm bringing a gun, but what'll give me the edge here? And so I was sitting looking at my schedule and I got it. We had 2 offices in McKinney that were 2.5 miles apart on the same street. Okay, on the same street. We had one that was all paid for with 10 ops, and we had another one, 6 ops down that was all paid for. It's just, we couldn't expand where we were. And so I'm going, we averaged 17 new patients a day in those 2 offices. And so all I did was this, it was a Friday, is I just printed off the schedule because their phone numbers were on there, and I called them. They weren't scheduled with me. They were scheduled in hygiene, or they were scheduled for an emergency. And this is all I said. Call them up and just go, bring, bring, bring. Mrs. Jones, hi, this is Dr. Michael Abernathy. I understand you're coming in at 10 o'clock on Monday to get your teeth cleaned. I just wanted to call and see if there was any question I might answer to make the appointment go smoother for you. It never failed. I'd go, Mrs. Jones, hello. I mean, they were so surprised that I had taken the time to call them. Now, I never told the front desk. They'd already confirmed the appointment. I never told the other doctors. I just did this while I was at the office. It took me 10 minutes to do this. I started tracking that for about 6 months because I was curious. But I remember on Monday, the first time I did it. Now, we had a doctor there, Matthew Markham. Guy was about 6'1". He had black, wavy, almost like Superman hair, where it's got this nice wave, but it's always blowing, I mean, it always looked that way. And he had like 6-pack abs and like 3 heads on his triceps. And, he had a deeper voice, and he's really good dentist. I mean, just really social and stuff like that. I mean, I had one patient that saw him walk down the hallway and said, is that guy married? Because I'd like to have a big glass of his bathwater. I mean, it's like, you're just kind of going, it just made you feel terrible, right? And so but I remember it's Monday morning, and we were open Saturdays, but I mean, that was the next time I worked. Okay, so it was Monday morning, and I told you the 2 times hygienists are upset at you is when you're waiting on you and when you're in the room, they want you gone. And so I got very good at when they wanted me, when they were ready, I got in there quickly. So I was walking through the sterilization area, and Dr. Markham, who never saw me, he was up in these 3 operatories up here, and I was way on this side, hygienist on the other side. He walked around and went right into that room. Now, he never saw me, and I was just going to turn around. I went, that was one of those new patients. So I walked over to the back, where the power panel was, you go in, and I just sat there as he walked in, and he goes, hi, I'm Matthew Markham, and I mean, his hair was blowing and his abs were rippling, and, and I'll never forget what she said. She goes, oh, well, I was hoping to see Dr. Abernathy. And now that wasn't unusual because I'd been there, I mean, my whole life. My family lived there forever. Okay. So, and as a lot of people, just my name was more common and they might ask, come in. Okay. But it was one of the ones I called. So I just tapped him on the shoulder. I mean, I out in the hallway went, yeah, and I walked in and, tapped him on the shoulder. He says, I got it, Matt. And he says, okay. And so she goes, oh, it was so nice of you to call me, Now, so I tracked this for about 6 months. Okay. Now, what I found is that our cancellation and no-shows for new patients went to almost 0 on the patients I called, almost 0. And 37% of the patients that I didn't check. Now, we got 2 offices. I worked one day in the 6-op office, 2 miles away, and I worked 3 days in the big office. So I was there Monday, Tuesday, Thursday, Friday. So Wednesdays I wasn't there, Saturdays I wasn't there at all. But 3 days a week I wasn't even in the Stonebridge office. And then 1 day a week I wasn't in the big office, okay? So there's a lot of times I wasn't there to check patients. But of the patients I call, 37% scheduled on my schedule, even though they had another doctor who checked them, diagnosed them. And okay, so I'm just telling you, if there's some associate out there and you want to just run ragged over your owner doctor, there you go. Just start calling him, Okay, authority. I mean, I realize that you may not realize this, Nathan. Prior to 1991, I mean, people wore slacks, dress shirts, tie, no jacket, okay? And we didn't wear gloves, we didn't wear masks. But in 1991, and I can't remember if it was 60 Minutes or 2020, but they ran a deal that dentists did not sterilize their handpieces. And that was true, we didn't. We disinfected them, we cleaned them, put them in the ultrasonic, put them in sterilization fluid, but they were steel ball bearings. And if we had put them in a chemclave, they'd last maybe 2 cycles and they just freeze up. But to counteract that, we started wearing gloves and scrubs. We wanted to look like a real doctor. Now, I don't know if you've been in a real doctor's office, but evidently butcher paper is an effective bacterial barrier because they don't spray anything when you come in there. They just pull the butcher paper down, tear it off, and next patient sits there. Okay, so again, authority. I think that you ought to get away from scrubs if you're still wearing them. Okay, I'm just telling you, it comes down to that reciprocity, authority. It comes out of Robert Cialdini's book. You need to look different than an average dentist looks. And so if there's some way you can distinguish it by just changing the way you dress, the way you act, the hours you have, that makes a big difference. Same day service makes a big difference. For me, especially, if I can get something done same day, I'm going to do it same day. But it cannot affect your schedule. Cannot make you run late. Okay. Cannot make you run late at all. So clinical speed, physical capacity, having enough operatories to do this makes a big difference. Pre-op phone calls, what we're talking about. We shade every patient that comes to our office. Why do you think we shade every patient that comes to the office? Nathan, why do you think I do that?
To help them become more aware of what they're
Yeah. Well, and again, I have the hygienist do it. they take the shade guide and like they're laying there and they'll just take that deal and put it up there. I said, and the patient goes, "What are you doing?" They kind of look at it, do it one more time, and then write it in the chart. Oh, he said, I was just checking the shade of your teeth. So a lot of times people come in, they want those black mercury fillings taken out, or they want some cosmetic work. I just wanted some kind of a baseline. And she says, "Well, can I see the tab?" Absolutely. And most of you guys don't grind the shade, the neck shade off your deals. You should, because it'll be a half a shade wrong every time you pick a shade. But you let them look at it. No matter if it was a B1, they'd think it looked ugly. I mean, it would, and so it is planting that seed, staging this to have them ask you questions. Because if the hygienist does it right, or the assistant does it right, and you have a non-assertive doctor, and they go, we were checking my shade and it was really yellow. Is there anything you could do to make that look whiter? Well, yes. But had she not asked, a non-assertive doctor wouldn't have even mentioned it. So there are ways to set this up to win. Okay, pre-op phone calls, shading every tooth, camera and imaging. We take pictures. I mean, I had a Sony camera. It was $50,000. The very first Sony cam was $50,000. Now, that was back when doctors were making $50,000 a year. Okay. Wow. It was expensive. And it was, imagine those old tube, and it was probably only a 30-inch screen or 25-inch screen, but you could barely lift it. And then it had the camera, which was, huge. It was probably 1.5 feet, 2 feet wide and 6 inches tall. And then you had the printer that was on there that printed like a Kodak deal to print out the picture you did. Didn't have computers to do that at that time. So again, I couldn't get my staff to use the camera. I just spent $50,000 on this camera, and they weren't using it. So I said, "Look, I'll pay you $1 a photo. And you have to use the camera." And it was a hassle because they roll it from room to room. I went, "Okay." And then I think I had 2 hygienists at the time. And they went, "Okay." So, and my hygienists were exceptionally smart. They go, "Okay, so if I take a picture, I get $1? Yes. What if I take 2 pictures? You get $2. Okay. And so all of a sudden, for the first week, they were taking 10 pictures on every patient, right? Now, before, they didn't have the time to do this. And we stopped that after the first 10 days. I went, "Okay, you have no excuse. From now on, you don't get paid if you don't take pictures. I'm not even going to check you. So start taking the pictures." Okay. So camera and imaging make a big, big difference. Staff recommendations. You don't realize when I say staging this, we went to an Elton John concert Saturday night. And, with him, they didn't have a lead up band. For most concerts, they have a band that kind of warms you up, and then the headliner comes on. We went to a James Taylor deal and they had that. So the staff recommendations about the doctor and the treatment make a huge difference. For example, by the time, let's say somebody that's never met me, by the time I walk in the room, the staff have told them how gentle I am, how quick, how many patients love me. I mean, she's really painted a great picture of it. Now, again, if your staff couldn't say that about you, maybe you have something to work on. But I mean, they did. They said those things. And then again, we mentioned the urgency and the handoff and stuff. So we'll finish with this. This is kind of the culmination of 4 or 5 of these. And I'm actually kind of sorry that I don't get to talk to you more, but I'm planning on seeing all of you that Thursday evening before the Friday where, Nathan starts his seminar, and I'll stay there as late as you want, because I'm going to stay in the hotel. I mean, if it takes 2 or 3 hours, whatever, I'm going to let you design the seminar. I'm going to ask you, what do you want to hear about? I'm going to put it on a board, and I'm not leaving until I talk about everything you want to talk about. Okay. So I want to finish with this. You can't be special, distinctive, or compelling in the marketplace unless you create something special, distinctive, and compelling in the workplace. Okay. You have to become accountable for the culture you create. And systems and protocols are things that build on that foundation of culture. Thank you very much.